Well, first of all, I want to thank my friend Magdi for the kind invitation to this terrific meeting. It's very stimulating, and as you see, there are so many questions that come out. And the title of my presentation is The Revival of Clinical Research. Why? When I entered cardiology, we had only the ECG and the chest X-ray and the stethoscope. Could ask questions. We had very little in terms of tests to measure things. But we had some deeply rooted beliefs. At the time when I was in the early 60s, the angina, myocardial infarction, were thought to be the result of coronary insufficiency due to the progression of coronary atherosclerosis that gradually reduced coronary flow reserve and then blood flow, and that would cause angina on effort. And then, when more severe, the coronary insufficiency would cause myocardial infarction. And myocardial infarction thrombosis was thought to be an epiphenomenon. Now think about those days. What I want to say is that those beliefs, because they were not based on documented fact, led to changes that were in research trying to find drugs that could bring back coronary flow, could increase coronary flow. And so dipyridamole was developed, which increased coronary flow, didn't do anything for angina. And it took years and decades to change the orientation of research. So now we have made tremendous progress. And but I think that the glass is half full. And to fill up the glass, I think that besides the biomolecular research and the statistical research of trials, we need to look back at patients that don't behave like they are expected. So there could be serendipity, single cases, or just look at the things from a different angle. We're always interested in finding what's the average risk, what's the average response, what's the average improvement in survival. We have to change this has given most of the fruits that could give. And we need to change the angle from which we look at the problems to develop new questions. And I'd like to give you a visual image of what I'm trying to say. You see, if you look at this rock, it's a beautiful Mediterranean rock in Italy, and I can tell you that you can look at details of the rock. You can tell you, okay, look within that circle and see what you can find. If you could go closer with your boat, or you could take binoculars and look in this direction. And I believe you realize it would be difficult to find what there could be there. So an alternative would be to look at this rock, what within this circle, from a different angle. If you look at problems from a different angle, you see them in a different way. You ask different questions. And that's what I'm trying to convince you. Let me see if I succeed. You see, if I look at it from a different angle, that's what it was there. There were these two rocks. I could never see them if I didn't change my views. We keep asking the same questions from one meeting to another. We have to start changing the question that we're asking. And so we should not worry so much only about the mean, but we can start considering the dispersion of values about the mean. And why the patients that are on one extreme or the other extreme, why are different from the other? I show again some facts. It's an old slide, totally forgotten by the Pooling Project, an international post-mortem study. They look at patients that died with coronary death or patients that died of non-cardiac death. They open the coronary arteries with the scissors. They open them flat, and then they planimeter the area of the raised fibrous plaque. So it's a very reliable way of quantifying the extension of atheroma. And you see, that's what is the message that has been left by the study, is that there is a large difference between patients with coronary death and non-cardiac death, particularly in younger ages. Again, see that already, if you go to the age of 60, 70, the means are not so different. But they are very different at the age of 30 or 40. And this is the message that remains. What I'm saying is, looking at a different angle, where you can see that there are two rocks there that you couldn't have seen anyway. Instead of looking only on the mean, you just look also at the dispersion of points, of the individual data points. You see? You see what a tremendous variation there is. So you have at one extreme, up there, at the top, you have there, here patients that had a coronary death, and yet you see they had less than 1/3 of their coronaries covered by raised fibrous plaque. At the other extreme, these patients that die of non-cardiac death, they have more than 2/3 of the coronaries covered by atheroma. And you see, we keep asking the vulnerable plaque, but is there a vulnerable plaque alone, or are there many that activate simultaneously? That would be a very important question to ask, because if there are many plaques that thrombose simultaneously, it means that there is a systemic involvement of the coronaries during that acute coronary syndrome. But that could be true in some patients, but not in all. We have to accept that patients are different one from another. And then I'd like to show you another example. This is one of the reports from a study that we recently completed, the collection of cases, where we took blood samples in patients that came in with their very first myocardial infarction without any history of coronary disease before, within 6 hours from the onset of symptoms. And we collected these cases in Italy, in Scotland, and in China, all metropolitan areas. These patients were ST segment elevation myocardial infarction. 90% were revascularized, so, well, they were really, and they were sampled very early. At the time when we sampled, we look at C-reactive protein, and we compare it with controls. And there were about 300 patients in China, in Italy, and in Scotland, all metropolitan areas. So, look, the way data are usually presented is the median and the quartiles. And you see the difference between patient and control is highly statistically significant, as all the literature would say. So you could stop there and try and say, okay, now we'll measure CRP and treat all the individuals that have CRP values above 2. Now, in this article, in all 3 countries, China, Italy, and Scotland, 41% of patients had CRP less than 2. Yet, you see that the median is significantly different. But look at the individual data point. Can you see the overlap? How can we use something that has a large spread, large overlap, like a single thing? We really, should concentrate on looking at the extremes and find out how come, what these patients here had a myocardial infarction. They had still ST segment elevation because it's within 6 hours from the onset of symptoms. Their troponins were negative. And yet they are having an infarction in spite of having a C-reactive protein so low. That is looking at the problem from a different angle, where you can see that there are two rocks instead of just a single block. And as you see, the thing is similar in all the three countries, Italy, Scotland, China. And you see the same wide overlap between patients and controls. You see also that the values are rather similar in the three countries. It means that in metropolitan area of Italy, Scotland, and China, what matters is lifestyle, which is metropolitan lifestyle. There could be some small differences between Scotland and others that are statistically significant, but they are very small. The large problem is that in all three areas, values of C-reactive protein are the same. And again, you have a lot of myocardial infarctions that occur here, 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 with values below 2. 41% in each country had myocardial infarction in spite of the fact that C-reactive protein was less than 2. So, skip this. You see, this is another way I'm trying to show you that by looking at the extremes, you can understand. This is a drawing by Escher. And if you look, it's difficult to understand what it means. But if you focus up there and down here, you can clearly see that here there is a fish and here is a bird. And in the middle there is just a large overlap. So looking at the extremes, looking at the outliers, at the patients that are not supposed to have an infarction, yet they have it, or those that have high C-reactive protein, high risk factors, and yet they do not have a myocardial infarction. What protective factors do they have? If we can answer that question, we could develop new strategies for prevention that are unthought of because now nobody ever considered the fact why some patients with high risk factors don't develop an infarction. That is the kind of clinical research which should dictate the selection of cases then to be studied with molecular biology and all the other tools to try and understand what is it that differentiates one extreme group from the other extreme. What distinguishes the bird there from the fish? So, and that can be done only with clinical research because we have to look at patients that are different from one another. And basic research should be applied to those patients. And cardiologists have the duty to select the cases, to submit the cases to the basic researchers. That's the revival of clinical research that I think should happen, and I hope it will happen. Thank you.
Thank you.